Hi, everyone. Thank you so much for joining us for this live virtual screening today. We're so excited that you're here and making time for this film and for this program. This screening is our European premiere, and we're so thrilled to be here with our partners in Sweden, Josephine and Daniel, the Swedish Society for EAET, as well as Marion in the Netherlands. We recommend you check out both those organizations, especially if you're from those countries. We'll put some links to their work in the chat. Thank you to those partners so much for gathering us all here. So many of you know that this understanding that you just saw, this treatment for chronic pain, it's not well known. It's very rare that somebody with chronic pain, as I know personally, will be recommended this sort of brain-specific treatment for chronic pain. And so we have a steep hill to climb to get these ideas out there, to make sure that people are informed that there's this whole other way of looking at pain. And so we're asking for you guys to sort of help us get these ideas out there. There's a couple ways you can do that if you wish. So one is you can make a donation. If you donate to this film, 100% of the proceeds will go towards publicizing these screenings, publicizing these ideas with these screenings around the world. We're going to try to do at least one screening per month for the rest of the year. And these screenings cost several $1,000s to put on. There's a lot of technology and staff that have to support it to make it happen. So that'd be great if you can make a donation. I specifically want to mention for anyone in the audience who has the means to make a large dollar donation, that will really help us allow for these screenings to be affordable so we can keep doing it. So it's like someone can join for $1 or even for free whenever we can. So please consider that. There's a simple link that will be in the chat to the side for you to make a donation. The second way you can participate in our screenings campaign is to host a screening for your community. So that you may think of a medical society or therapist group that you're part of, and you're like, gosh, I think they would be interested in this film. Please reach out to us. We have a staff that can facilitate these screenings so people can watch the film for for cheap or for free through their organization. So there's also going to be a link to that that's going to go in the chat to the side. We will get back in touch with you if you give us some information about your organization, and we would love to do these screenings. We've already done a dozen of them or so, and they turn out really great and people really love them. So consider that. And then the last way you can help support the screening series is just to tell people about the film. You can just send people our website. We have a pre-built email that you can find on our website to just send to a few people that you think would be interested, whether it's medical professionals, therapists, or just people you know with chronic pain who are maybe looking for another way to deal with their problem. Okay, that's the housekeeping. The next thing we're going to do here is we're going to do a Q&A. The Q&A will go for about 30 minutes or so, and then after the Q&A, there's going to be a totally optional Zoom discussion where you can join with a small group discussion. But before that, we're going to have 30 minutes or so to ask questions. I'm going to introduce our panelists now. So we have Dr. Howard Schubiner, who you just saw in the film. Howard has been treating chronic pain patients for nearly 2 decades, and he's recognized as a leading researcher in the field. Nowadays, much of his time is devoted to teaching doctors and other healthcare professionals about how to do this work. We also have with us Dr. Mark Lumley, who is a distinguished professor and director of the PhD program in clinical psychology at Wayne State University in Detroit, Michigan. Mark Lumley conducts research on the role of stress and emotions in somatic health. He's published over 170 peer-reviewed articles, and he has had multiple grants from the National Institutes of Health. You may also recognize his name. He was one of the co-authors of the fibromyalgia study that was featured at the end of the film that he and Howard conducted and co-authored together. They'll speak a little more about that in just a moment, I'm sure. And then next, I'm going to turn over this to Marion, who's going to lead the Q&A.
Hi, everyone. Thank you so much for joining us. I think actually our first question is for Kent. I think our audience would love to hear about your struggles with chronic pain and how they inspired you to make the film. Could you talk a little bit about that?
Yeah, sure. So I am a chronic pain patient myself. I had really debilitating arm pain when I was 22, and I was put on, I was recommended physical therapy and 100 different things. I read a whole book about tendonitis, and it slowly got worse and worse to the point where I was put on opioids for my pain, and nothing worked. And then I read a book by Dr. John Sarno and had a pretty dramatic and rapid recovery. After that, the pain moved all around my body, and it was really just a crazy, eye-opening experience about what the mind and the brain can do and manifest symptoms in the body. So yeah, that was an amazing experience, and it really made me think that it was kind of crazy that none of my doctors had heard of this other way of treating chronic pain. They didn't recommend it. When I told them about this other way, they kind of didn't seem to care or think it was relevant for any of their other patients. And I think that was a big motivation to want to make this film, so that this treatment would at least be on the menu. It would be something that doctors had heard of and therapists had heard of, so that they could offer it to other people like me who might have this problem with pain. Now I have a question, Marion.
Yeah.
Can you tell us a little bit about how this film came to be?
Yeah, so This Might Hurt was truly a labor of love, and we do say that lovingly, but we worked on it for a number of years by ourselves because we didn't have any financial support. So you and I would work on it on nights and weekends. And it was a struggle. We actually were only able to film the first the classes, because you had a break in between two jobs and you were able to fly yourself to Detroit and start the filming process. So as I say, it was a labor of love, and it took a while, but we were really committed to finishing the film. We really felt like the stories we had could really help folks and could help chronic pain patients, could help doctors, therapists, people who are, working with pain patients, who are seeing patients come into their office and don't always know how to help them. We think this, might be one way that can really help people. So we struggled and we finished it. As I said right before the film, we went to Austin Film Festival in October 2019, and we're going to go to a bunch of festivals in 2020. But of course, that didn't happen. So we're so excited to have these screenings and help create a sense of community and connect people who are all interested in this topic. So thanks everyone for being here. Our next question is for Howard. Could you talk to us a little bit about how the treatment has changed, since we filmed? Because as I mentioned, we did it a number of years ago.
Well, my hair, I noticed, is a heck of a lot grayer than it was then. And I'm a lot wiser too. Mark Lumley and I, who you'll be hearing from shortly, have worked and refined some of these therapies. I've worked with Allan Abbass, one of my main mentors, Helen Gordon, and a bunch of all the other people in our community to refine this therapy. And really, it's quite different now, I would say, in a variety of ways. But the basics are still the same. The basics are making an accurate diagnosis of the cause of the pain. Because if you make an accurate diagnosis, people will know that maybe they're not actually injured. The vast majority of people with chronic pain don't have a structural problem in their body, according to our research and my experience. Then it's working to educate people about how the brain works, pain neuroscience, and then it's calming the brain, helping people to move, to be less fearful, less worried, less afraid of their pain. And then it's looking for underlying emotional issues that cause it in the first place. And we've been, again, refining those techniques as well of how we do that. We just try to be bold and careful and cautious at the same time. Maybe Mark could speak to that as well.
Yeah, Mark, do you want to say a little bit about that, and also how you and Howard started developing the EAET framework?
Be happy to. And thanks, Kent and Marion, for having me on, and good to work with you again, Howard. And hello to all of our friends and colleagues around the world. The issue about risk, boldness versus caution is one we should probably come back to, because I know there's questions people have about the possibility of re-traumatizing people. I will say briefly a little piece, which is most therapists that I know of are really cautious. And in their caution, they avoid emotionally important topics. There's often two people in the room, patient and clinician, who sort of collude to not do things that feel a little scary or risky. And so I personally am trying to push back on that a little bit by reminding people that we have to move towards things that feel a little dangerous but are not truly dangerous. And that's a lot of what about this EAT and related approaches are about. You asked about how Howard and I got together. A good friend of mine was an administrator in Howard's hospital, which is we're in the same community. And he said to me, "Mark, you got to meet this guy named Schubiner. You guys are kindred spirits." So I reached out to Howard and attended one of his presentations, and I said, "Yep, we are kindred spirits." And that was probably a dozen years ago. We've been collaborating ever since. The project that we sort of stumbled into this thing we're calling emotional awareness and expression therapy by doing a series of studies together and refining it. But a big piece was when we went together to Halifax, Nova Scotia, and met with Allan Abbass during one of his trainings, and got influenced by ISTDP, which we sort of infused in some of the other work that he and I had both been doing on expressive writing and on pain neuroscience. It sort of has evolved into this thing, which, as Howard mentioned, is still evolving as we gain more clinical experience. So we've had a great relationship. Howard sits on several of my doctoral students' dissertation committees, and we work on grants together. He brings the clinical expertise. I learned so much about him from his work with patients. I bring in some theory and research piece, and I think we make a great team.
That's great. Thank you. Howard, I want to talk a little bit about trauma. We see 3 patients in the film who do have pretty clear traumas, but certainly we know that this type of work can help people who don't have as clear traumas. So can you tell us a little bit about that? Do you have to have a trauma? Do you expect that every patient will uncover buried trauma, or can you still heal without that?
Yeah, that's a great question. Everyone has some trauma. I mean, depending on how widely and, how you define it. I didn't have an abusive childhood in any way, shape, or form, but yet I learned to be sensitive. I learned to be a people pleaser. I learned to be afraid of conflict. And so when those things kind of came up in my life as an adult with kind of the normal stresses of fathering and work and everything, I started getting neck pain. I started having diarrhea. A variety of things happened that were physiologic responses to the stress in my life. And clearly we know that people with adverse childhood events have much higher levels of pain and other somatic conditions, a lot of other conditions as well in adulthood. And so, but not everybody does. A lot of people have trauma in childhood and don't have these adverse outcomes in adulthood. So what we say is that, we make an accurate diagnosis and we start on the brain retraining, or what we're calling pain reprocessing therapy first. And then we see how people do. So some people do great with that and really don't need to dig deep for underlying trauma or touch deep emotions in order to recover. On the other hand, some people do, and it can be, as you've seen in the film, extremely helpful.
Thank you. Mark, I want to talk to you a little bit about how therapists who aren't necessarily familiar with EAET, or maybe have a chronic pain patient, in a session this week, but can't learn it yet. How can they use this work? Maybe if they're even from CBT model or any other model that isn't necessarily talked about in the film, how can they use this work to help their patients?
Yeah, great. And there are a world full of therapists who are never going to get specific training in this approach. So what do we do with the huge numbers who are comfortable with CBT or psychodynamic approaches or a whole range of others? I'll confess, by the way, that I don't actually like using the term EAET because it's just one of many, many therapies that are competing for marketplace, and I'd rather talk about core principles. So I suggest to therapists that they think of several things. That for many types of pain, it's more about the brain than it is about the body that's driving the pain, this centralized pain syndromes, if you like. And the brain is changeable, and it's most changeable when people have powerful, emotionally based, emotionally laden experiences. It's not as powerful if you just think different thoughts or engage in some different actions. It's most powerful when you approach those things that have been scaring you, whether they're traumatic memories or difficult relationships. And so the key principle would be to, as quickly as you can, after giving a message of the changeability of the brain, is to identify those things that patients are avoiding that are emotionally salient and help them go there, even though it's scary, and to overcome the fears and the defenses and barriers that they have. And quite honestly, the core emotions are usually something dealing with anger, and fears about experiencing and giving some voice to anger, and then often fears of sadness and tears, or intimacy and love and connection. Those are the core. And so we try to shift people out of a place of being stuck in their emotional and relational lives into a place where they can move forward by facing those emotional experiences and resolving them or overcoming them, or developing some courage. And so that tends to be the core principles. And people with exposure-based training and post-traumatic stress disorder can do this. People with psychodynamic training who are used to thinking about defenses and emotions can do this. But it does take some courage to go after those unexpressed emotions.
Yeah, courage from both the patient and the therapist, probably.
Even people like me can do it, you know, if we're careful. And you know, I mean, I had to learn to do this kind of work primarily because I didn't have therapists that I could refer to. So I kind of started learning on my own with Mark's help and Allan Abbass's help, of course. Anyway, sorry to jump in there.
Yeah, that's important information. We have a commenter who mentioned that their pain started during pregnancy and then the pain did not stop. How can pregnancy and raising kids be linked to the onset of pain? As you mentioned, you maybe had some pain linked to that as well.
So you think that being pregnant or having kids can be emotionally upsetting? I mean, these are the major events in our lives, and especially, you know, think about it. If you're about to have a child, whether you're a man or a woman, you know, that's going to bring up all your own upbringing and how your parents were. And I can't tell you how many people I've seen who had fears of being the kind of parent their parent was to their child, or putting so much pressure on themselves to be 1,000 times better parent to their child than they were. And so these things just bring up a lot of emotions and a lot of stuff that can trigger pain. Now, why does the pain persist? That may be a slightly different reason. So a lot of times pain can occur, or other symptoms like fatigue or insomnia or anxiety or depression. And we really put these all into a similar framework as brain-based, brain-generated neural circuit disorders that are interchangeable and flip from one to the other. And again, as Mark was saying, can be reversible. Anyway, so, but an emotional event or stressful life events can trigger pain in the first place. And sometimes what causes the persistence of pain is actually the fear of the pain, the worry about the pain, the focus on the pain, the frustration with not getting better, the seeing doctors and not getting answers, or getting diagnosed with a label that seems incurable or crippling, like fibromyalgia or chronic Lyme disease, or nowadays long haul COVID or Ehlers-Danlos syndrome. So what starts the pain and what continues the pain sometimes are distinct features. And the point of our therapy, as I was saying earlier, is to try to address both of those things, the brain retraining part and the emotional expression part.
Great, thank you. Mark, and Howard, I'm sure you have thoughts on this too, if you want to pick it up after Mark, but you know, we made this film a number of years ago, and a lot has changed since then. What additional research do you think is needed around this work and in this field?
Great question. And I hope the folks at the NIH are listening. We actually have a grant we're submitting right now to see how EAAT compares with the leading approaches. In the States, the leading approaches are cognitive behavioral therapy and acceptance and commitment therapy and related mindfulness and acceptance approaches. There's only been a couple of studies that have directly compared them. And right now, EAAT looks to be somewhat better than CBT in a couple of studies, but a lot more work needs to be done there. So we're looking for a large clinical trial that'll compare all three of them. We also need to look at who's going to benefit from each, because it's probably the case that there's different predictors. Not everybody's going to benefit from this approach, and they might need a pain management approach like CBT or acceptance-based approach. And so understanding the individual differences would be really important as well.
Yeah, just to add, there's a lot of conditions. We've done randomized controlled trials in fibromyalgia, in back pain with the Boulder back pain study that hopefully will be published shortly. But we haven't done headache studies or migraine studies. We haven't done studies in chronic pelvic pain, irritable bowel syndrome. I mean, we treat those every day, and we see success with those. Like I said, they're interchangeable. If it's a neural circuit disorder, it's a neural circuit disorder, and the same treatment approaches apply. And in addition, diagnostic, we're doing a study right now. Mark and I are working with a PM&R doctor, a great doctor in Louisiana, and we're doing a diagnosis study of people coming into his clinic with chronic neck and back pain and diagnosing them accurately and seeing what proportion of people with chronic neck and back pain, unselected for whatever cause, anything they have, how many of them would be classified as purely neural circuit problem as opposed to a structural problem or a combination of the two. And so far we've got I think Mark was just telling me yesterday, 150 people who are enrolled in this study, and the results, I will tell you, are surprising, and I think will be revelatory, shocking when we can publish them. So anyway.
Great. Howard, you both have talked a little bit about this too, but we have some questions from folks who mentioned that other therapies go a lot slower than you did. You know, you did this class in 4 weeks. And so how were you able to create that amount of change so quickly? Is it the way you still practice now? And, you know, what do you do when patients just aren't getting through? How do you continue to motivate them on this journey?
You know, we're doing things differently, I would say. I'm not doing personally. Other people are doing groups. I'm not personally doing groups where the main therapy is peer-to-peer. The groups that you saw at the end of the movie, Heidi, a fantastic therapist in Ann Arbor, Michigan. She's doing groups, doing the same model and doing great success with it. But she's not leaving people alone. You know, there's a therapist in the room whenever there's emotional processing going on. So by and large, as far as I know, most people are doing that. But it's all about safety. It's all about compassion and safety, and as Mark was saying, giving people this cocoon to say it's okay. It's okay to feel emotion. Emotions are not dangerous. Anger is not a bad emotion. It's not unhealthy. It's not negative. It's powerful. It's protective. It's important. We just can't put anger out in the world in terms of violence. That is unhealthy. So it's all, you know, and that's one thing I learned from Allan Abbass is it's really about love. It's really about compassion and love, and allowing people to have their voice, to be compassionate toward themselves. And going through this process, the goal is compassion for themselves and compassion for others and forgiveness. So really, that's what heals. That's what heals in the long run. And so we're really excited about being able to do this, and people respond to it really well when you give them the safety and the place and the love for doing this. And all therapists do that. I mean, that's what you learn to be a therapist, to set up that safe space. And we're just making sure that safe space includes emotional expression. And if people have a hard time with that, then we go slower, and then we do smaller, and we help them in micro ways. And that's what graded exposure really is all about. And graded exposure, as every therapist knows, is just a great way to work behaviorally and emotionally as well.
Yeah. Sorry, Mark, I'll just, you can finish. I'll just have to say this one thing. There was a patient in the film, Arnie, who didn't get a lot of screen time, but he was the older gentleman, and he, became clear very quickly that he just wasn't going to be able to do the emotional work like Kim and Maureen. And so Howard worked with him on a much more behavioral process. And he, you saw him on class 2. He was already standing out of his chair and saying he couldn't do that, 6 weeks ago. So there are lots of ways to approach it. Mark, what were you going to say?
Yeah, I like what you said, Howard, about the graded exposure. Good clinicians sort of make judgments as to what the patient can handle, but patients also communicate that. And if you start seeing patients who are really struggling with their thoughts, their perceptions, they shut down emotionally, that tells you back off the intensity. But another piece of the work we're doing is, unlike some therapies that basically say, we want you to relive your trauma, maybe even repeatedly, like in some exposure therapies. What we're saying is, let's identify those avoided healthy emotions that are probably present, but that you've not given voice to. And that's a different thing than just having people feel the disgust, the shame, the fear, the all those things that are kind of that they normally are experiencing, and to identify what it is that they've not given voice to. And that tends to be pretty empowering and then relieving and less scary, and less likely, I think, to traumatize or to re-traumatize. But a bigger picture for me is thinking about the huge number of therapists, most of whom are oriented towards not taking any risks, just being safe and make sure the patient is comfortable and make sure the patient is ready. And often that leads to basically not doing anything emotionally activating or engaging or healthy because of these fears that two people in the room will share, the patient and the clinician. So I want to sort of push back against that overarching fear that we have in our field that says, unless you're sure it's going to work, unless you're sure, don't do it, because you never know. That fear is also what drives pain.
Right, and it's really the idea of not re-traumatizing people is critical. It's so critical. To go back and relive the experience over and over again is just cruel. But to go back to the experience and change it, to use memory reconsolidation techniques, to go back and express things, as Mark said, that couldn't be expressed, and imagine things that couldn't be imagined, because our memories change, and our memories of the past are what constitutes what our past is. And as we do this work, we're helping people actually change their memories, which is freeing. It's amazing how liberated people feel when they can alter, re-narrate their own prior experience. And a lot of people are doing this in a lot of different ways. Mark and I have a good friend who's a hypnotherapist who does this kind of memory reconsolidation work very effectively.
Great, thank you. Mark, could you give us a quick overview on some of the acronyms we've been using, ISTDP, AEDP, EAT, and EDT, but potentially just put them into categories and give us a little bit of explanation about how they differ?
I'll try to make it quick. And I know a lot about ISTDP and EAT. The accelerated exponential dynamic therapy I have seen a little bit of, but let me suggest that most of these have more in common than differences. They all value helping people to go to emotional places they've been avoiding. They might do it differently in the intensity. So ISTDP, I think, tends to be the most intense. ISTDP, which I like, it's a sophisticated and nuanced therapy to learn. So there's a lot of individual differences that are negotiated. The therapist has to negotiate how intensely they go. It works more in the transference, the complex transference reaction. I like EAT, though, again, I suggest we just think about the principles, but it's a simpler approach, perhaps more naive. And the others are sort of other offshoots that also bring in emotions and newer relationships and dealing with the defenses. I think they have most of those things in common. I hope our field moves away from these separate acronyms and separate therapy types and starts looking at the commonalities or the most common processes and common mechanisms that cut across these therapies. I'd be happy to get rid of the term EAT eventually, for example, and just go with the core principles of effectiveness.
Yeah, that's definitely an interesting discussion. I'm sure folks are going into in rooms across Zooms across the U.S. right now too. And
at the same time, I'm like, Mark, we got to do. People are emailing us and saying we want training in EAT. Mark, let's do some trainings, and so it's. But as you point out, Mark, I think the beauty of this is we can do trainings in the processes and teach people the principles and processes to use, as opposed to having a acronym to put on their wall or something.
Howard, we've got a couple questions from the audience of people who, believe that they might have an emotional component to their pain or a behavioral component, but they are seeing scary MRIs over and over again. Their doctors are telling them they're injured. What do you say to people who are having that experience?
Yeah, this is the core, basically the core of what I do every day, seeing patients. And there's two main sources of this kind of medicalization or medical trauma. One is the test results, and two is the labels that people are given. And I mentioned the labels a minute ago. The test results are critical because, and a recent study just came out showing that the way radiologists read and the way orthopedic surgeons and neurosurgeons read MRIs, they read them to make them more scary than they really are. And what I do, I show people the data of what percentage of what they have is normal. So 50% of 30-year-olds have disc degeneration who are healthy and have no pain. 50% of 30-year-olds have disc degeneration or healthy and no pain on MRIs. And that's 80% of 50-year-olds have that. So these are all normal findings, the disc bulging and the degenerative disc disease and the facet arthropathies and most of the spinal stenosis. So I just give them the data, number one. Number two, I say, look, everyone has this. I do. Look at the MRI of my neck. My neck looks horrible. It's just as bad as yours, if not worse. But I'm not having neck pain now anymore. And then the third thing, what we do is we look carefully in a detailed way at the characteristics of the pain. If your pain's there in the morning and gone in the afternoon, that's not a structural problem. Structural problems don't do that. If your pain is triggered by stress, that's not a structural problem. If your pain is triggered by the weather or wind or cold, that's not a structural problem. If your pain shifts from one side of the neck to the other, or one side of the back to the other, or has been spreading over time, these are all characteristics that we've written about, and I can send anybody a document of how to assess that in people, and it's in the books that we've written, and it's in the trainings that we do. And if anybody wants to be on our email list in order to get notifications of new research, of trainings coming up, of any new articles that are being published, we're always putting those out. So just let us know and we'll be happy to put you on that list. And so you'll be updated as this field changes and grows.
Thank you. That's really helpful. Yeah, there are a lot of resources out there. So feel free to get in touch with us at thismighthurtfilm.com or Howard's site, unlearnyourpain.com. Mark, we have a question about this work for children. In the film, Tony was 17 years old, but he had his pain had started when he was 12. And I imagine there are a lot of kids, and maybe a lot of kids who are currently experiencing a global trauma right now, who might have some pain issues coming up or anxiety. So are there books and resources specific to working with children around this work?
I'll confess, I don't actually know. I'm not a child clinical psychologist, and I really admire my colleagues who are, because they have extra challenges, I think, in working with kids, which is families and development at the same time. Just a few thoughts. I gave a talk to a pediatric program the other day, and the topics came up like they have a lot of adolescents who have a recurrent abdominal pain, and headaches often start in the teen years. But one of the core issues is that many of the traumas that we work with adults are things in the past, but for many kids, it's in the present, often in the family that they're still with, which I think makes therapy more challenging. But I suspect, and it also might require bringing the family into a therapy, but the core principle of recognizing that these pain problems are often not permanent, structural, but brain-based is a key piece of it. And that helping to put experiences into words, emotions, give them some voice is really important. And so I think those, you might have the family pushing back on that, or the child being very afraid of it, or younger children might even have language problems in terms of not enough sophisticated introspection or language to do so. But I think working towards helping people put their struggles into language would be very, very helpful for children and adolescents.
Great. Howard, do you have additional thoughts on that?
Yeah, we really need more resources in this area, and I've been just spinning the back of my mind of thinking about who can I work with. Is there somebody that really is interested in this area that we can put out some pamphlets or a book or a manual or something? I mean, a lot of times kids get better when you change their environment. When their environment changes, they can turn around on a dime because, you know, the stress is less and the symptoms just melt away. The problem happens sometimes when parents are so medicalized. We see this a lot where the parents are taking the kid to, you know, so many different doctors and getting so many treatments, and that unfortunately can be counterproductive because you're making the kid feel like they're really sick. Why else would they be taking medicine and going to all these doctors and getting all these procedures? And the parents are asking them all the time, how's your pain? How's your pain? How are you feeling? How are you feeling? And it's really, that whole dynamic can be difficult.
Right. So we have gone for about 35 minutes now. We'll just take one or two more questions before we break into the Zoom rooms. But Howard, we're getting some questions around COVID long haul. How is your understanding of COVID long haul syndrome changing as it applies to this type of work?
Well, we certainly know that people with significant coronavirus infections can have chronic lung damage, chronic heart damage, following, in particular, following these infections, particularly people with serious and severe infections. There's been this is a huge issue of long haul COVID. There's literally hundreds of thousands of people involved, and it's probably around 10% of the people who are infected have what's been identified as long haul COVID or self-identified. We don't have a lot of data on it yet, except that it's extensive. There's a lot of people with it. The symptoms are primarily brain fog, fatigue, trouble concentrating, chronic pains, headaches, a whole variety of symptoms that are the same symptoms we treat all the time in people with chronic fatigue syndrome, fibromyalgia, chronic Lyme disease, etc. And so I've started to treat a few people with this, and so far everyone I've treated has had a brain-based problem, and they did not actually have disease due to COVID. So a lot more work needs to be done on it. About a third, roughly at least a third of the people who identified as long haul COVID have never had COVID or have never had a positive test for COVID, and yet they have the same symptoms. And COVID and this whole pandemic has been such a worldwide traumatic event in so many ways. It's hard to imagine that anything more traumatic on a worldwide basis could happen. And of course, people's brains are going to be afraid. Of course, this danger signal in our brain is going to react. And some people, especially those with prior trauma or histories of anxiety, depression, etc., are going to be much more likely to have symptoms that can be lumped into this category of long haul COVID. And we're starting to do some studies on it, and we're desperately hoping that it doesn't get over medicalized. And we're desperately confident, I think, desperately confident. We're optimistically confident that using this approach can help a lot of these people, if not most of them.
Sorry, I was on mute. Mark, we're getting a question from the audience. Is there a correlation between highly sensitive personality traits and chronic non-structural pain?
Yeah, there's been a lot of research on personality traits over the years, and it's linked to pain. Perfectionism, insecure attachments, something called neuroticism, which is sort of a tendency to worry, to have negative emotions. Introversion, which is tending to avoid relationships often because of some anxiety in relationships. Those things are all been linked pretty reliably, and in prospective studies, things that go forward in time, to the experience of chronic non-structural pain. Yeah.
Thank you. Okay, Howard, last question for you. For a general practice primary care physician, how would you recommend broaching the approach to your patients who might not be believing that it's possible that they have a mind-body disorder? How do you approach those folks who just can't get behind this theory?
Yeah, you can't, you're never going to force anybody to believe something they don't want to believe. And so, trying to force that is generally a really bad idea. But what I suggest for primary care physicians and other physicians is obviously they have to be brief. They don't have a lot of time, but it's to say, I care. I care about you. I care, and I want to do everything in my power to help you. And I can see how hard you've tried and how much you've put into this and how frustrating it's been for you to not get better with X, Y, or Z condition, that all these things have been tried and yet it hasn't worked. What can we do? I'm not ready to give up, and I hope you aren't either. Just having to live with it is not a great option. There is some new research and an emerging way of thinking about things that has been successful for some people. Are you interested in looking at that? And let them see what makes sense. And then you can send them to the PPDA, the ppdassociation.org, my website, unlearnyourpain.com. You can send them to the tmswiki.org. If they're in Europe, you can send them to sirpa.org, SIRPA.org. You can send them to the other associations like the ISTDP and the IEDTA.net. all these places that have information on this brain-body connection. And I've got a bunch of animations now. If you're interested, there's some like 5-minute animated videos on the topic that explains this stuff real simply and easily and hopefully engagingly. And then people can choose if they want to learn about it. But it's giving them the choice to say, is this something that you are willing to just open your mind and look at? And if not, fine, we'll keep doing the other stuff that we're doing.
And if you've tried everything else, it might be worth a shot, if nothing else has worked. If you've done everything else folks have offered to you, especially because Dr. Schubiner doesn't ask you necessarily to get off your medications if you're not ready. He's not going to tell you to stop going to your masseuse or whatever makes you feel better. He's just asking you to look at it in a different way. So thank you to our panelists for joining us. This has been a really great discussion. We will be jumping over to the Zoom shortly. Kent, you can talk about that in a second. But I just want to thank everyone for joining us. Thank you to Jonah Tabb, who's been beautifully directing these shots that you've seen from person to person. Thank you for working on a Sunday, Jonah. And just again, the way we spread the word about this film is by word of mouth. Unfortunately, we're not on Netflix or Hulu. So if you like this film, we'd love for you to, first of all, reach out to us. We'd love to talk to you about it. If you didn't like it, we'd love to talk about that too. But please tell your friends. We, like Howard says at the end of the film, are trying to change medicine. We are trying to make sure every patient is at least aware of this if it might be helpful to them. We're not, of course, saying that it's going to work for everyone, but if it's going to work for someone, we want them to know about it. So that's what we're spending the next year doing with these screenings. We hope you'll continue to join us. Kent, anything else?
Hi, everyone. Yeah, so just a few quick housekeeping, and then we're going to go to the Zoom room for the people who want to have a further small group discussion, talk about what the film meant to you, how it resonated or didn't. So we're going to send a recording of this this whole event, including the movie with the Q&A, to everybody who registered. And that will be available starting in a couple of days, and it will last for a few days. Let's see, there's going to be another screening in May, and that screening will most likely have continuing education credits. So our site is going to announce that in about a week or two, and you should get on our email list if you're interested in letting people know about continuing education. And then just real quick, a review. There's just a few ways, simple ways you can support the film and the film screenings. You can donate to the film. Go to our site, thismighthurtfilm.com. And the link is there in the chat. And you can sign up to host a screening. You can host a screening for as little as 20 or 30 people. Just get in touch with us, and we have a staff to facilitate that. It's one of the great ways to share the messages in this film. And then, of course, you can get your own personal copy of the film through our website. We sell a streaming license right now. You can gift the film to someone you think would be interested. And there's a lot of resources on the website, and we're going to continue to be adding resources about each of the major conditions of chronic pain on our website. Okay, I think that pretty much wraps up this.
Can I ask everyone to give Marion and Kent a huge virtual applause? I mean, you guys have spent so much time and so much effort over the last, I don't know, it's been 7-8 years now, and so much of your own money going into debt. The dedication is tremendous and the product is amazing. So thank you all. You're doing a service to the world. Thank you guys.
Thanks, Howard.
Thanks, Howard.
Yeah, so hopefully Jonah is putting the Zoom link in the chat. There's going to be a special room for people who want to speak in Dutch or who are going to be joining from Sweden. And so we encourage you all to jump over right now. Click the link. If you don't see it, it should be popping up there. We have 12 people in our waiting room. Oh my goodness, let me let everyone in. Sorry for those who are waiting. Here we go. Okay, once you join, you should close this other tab. Here we're adding people. All right, this is exciting.
So we'll see you there.
Faces. Yeah, so we'll see you over there, everybody. This concludes this broadcast. So